So with that being said, I definitely want to go over some questions that they're going to ask you about chronic heart failure for the IM boards. What about this 60-year-old man is evaluated during a follow-up visit for heart failure with a reduced ejection fraction? He reports stable shortness of breath and no hospitalizations since 2 years ago. He has no other symptoms. Med includes carvedilol, which is the beta blocker, spironolactone, Mira, lisinopril, ACE, the pagliflozin, SGL2 inhibitor, and of course some loop diuretic and furosemide. On exam, the blood pressure is 110/70, heart rate is 66. Remainder of the exam is unremarkable. Patient's serum creatinine level is 1.3. They do a recent echo that shows a left ejection fraction of 35%. This is going to be HFrEF. Which of the following is the most appropriate treatment? Well, you know what? Let's go back to what we're talking about. This sounds like we need to see if the patient's on GDDM. Are they maximized on this medication? And what can they benefit from? So looking at here, they mentioned this medication, Sigwad. We just talked about it. This is this medication over here. And what did I say, everyone? When do we can think about this? After the 4 pillars and patients who are getting a lot of hospitalizations. So is this patient having a lot of hospitalizations? No. So he's been doing great since his last hospitalization 2 years ago. This wouldn't be a medication. Ivabradine, did we talk about that? Yes. So when do you think about it? When someone is still tachycardic despite being an optimal beta blocker, this patient's heart rate is 66. So A and B are not going to be the answers. Do we need to crank up the beta blocker? I mean, 66 is pretty good. I don't think increasing the dose is going to be the right answer here. The last choice is switching lisinopril to brand name Entresto, the valsartan sacubitril combination. And what was the thought on that? Right here. Remember, based upon the classic paradigm HF trial, that we had better mortality reduction when we use sacubitril valsartan compared to ACE inhibitor. So the best answer in this case is going to be D. We're going to switch it to get the patient better mortality reduction. All right. And like I said earlier, that, valsartan sacubitril is going to reduce hospitalizations and mortality in patients with both reduced ejection fraction and preserved ejection fraction. That's going to be a very important point right there. What about this one? 57-year-old woman is hospitalized for a 2-day history of worsening dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea. On exam, blood pressure is 140/70, heart rate of 98, respiratory rate is tachypneic at 28, O2 sat is 95% on room air. There is JVP, there is an S3 on auscultation, crackles are heard halfway up the lungs, there is lower extremity edema to the knees, there was an elevated brain natriuretic peptide, and the serum creatinine is 1.2. So they do a chest x-ray, and what a surprise, it shows pulmonary edema. They do an echo, EF is 20%. So once again, this is HFrEF, reduced ejection fraction with diffuse hypokinesis. And what a surprise, he's in kind of that acute CHF. So he gets IV furosemide. We're going to put him on bi-level positive airway pressure. So this is going way back to the beginning of my lecture when we talk about acute CHF management. What do? Reduce the preload. 80 to 85% of patients are going to be feeling better. And even though I mentioned many things, probably the go-to for most people are going to be a loop diuretic if they have a lot of worker breathing, non-invasive, positive airway pressure. So which of the following is the most appropriate additional management? All right. So A is bisoprolol. So is an acute CHF exacerbation the most opportune time to start a negative inotrope, starting a beta blocker? The answer is no. At some point, should this patient be on a beta blocker? For sure. It's definitely one of the pillars right there. Diltiazem, which is a non-dihydropyridine CCB. Is there any indication to start this medication now? No, not at all. And this patient does have CHF. We always try to avoid calcium channel blockers if possible for pure CHF. So I don't see the mentality for that here. ACE inhibitor, well, that always sounds good. We do use ACE inhibitors when we talk about, the acute management. It reduces the afterload. And it's definitely one of the pillars when we talk about starting the 4 pillars up front. I think that's a reasonable choice. And last is D, ivabradine. Well, once again, controlling that heart rate in the acute setting may not be the thing to do. And also, you want to give a maximum dose of a beta blocker first. The patient is not even on a beta blocker. We won't do that because it's acute exacerbation. So A, B, and D don't make a lot of sense to me. What would I do here? This is someone who you could start off with these choices on an ACE. So there's still definitely people who need them on an ACE or ARB. They definitely reduce morbidity and mortality in patients with heart failure, whether it's maybe a reduced ejection fraction or preserved. And second bullet point is beta blockers, sure, but not in the acute exacerbation. Maybe wait till the patient's close to euvolemic, being close to discharge. So what about, this gentleman who's a 50-year-old man evaluated for management for heart failure with reduced ejection fraction, diagnosed 2 years ago. He has New York Heart Class 3. He has been stable for the past year. His medical history includes ACE inhibitor-induced angioedema, that can't be good, spironolactone-induced gynecomastia, and atrial fibrillation. An implantable cardiac defibrillator was placed, an ICD. Meds are losartan, carvedilol, SGL2 inhibitor, Lasix, and anticoagulation for the AFib with apixaban. On exam, patient is normal intensive, heart rate 74, and irregular. The remainder of the exam is normal. Serum creatinine and electrolytes are normal. Which of the following is the most appropriate treatment? Well, a couple things. Looking at what are my choices over here? Well, it says adiplerenone. Adiplerenone is a what? MIRA, mineralocorticoid receptor antagonist. Now, I would say, if he had, spironolactone-induced gynecomastia and he wants to switch, that's not a bad idea right there. I think I could do that. Adding ivabradine over here when the heart rate's 74, I can't say if he really, maximize the beta blocker. I don't think I'm super excited about adding that ivabradine in this case. Switch to carvedilol to metoprolol. I don't think that needs to be the right move. I would say we could always maximize the beta blocker first. Now, switching the losartan to valsartan sacubitril, which is going to be Entresto, in any other setting that sounds like a good idea, except this patient had what? ACE-induced angioedema. And one of the things to remember, which is almost a guarantee on your board exams, is once you get the angioedema, especially from an ACE, you cannot switch to the sacubitril valsartan combo because they really have a higher chance of getting this angioedema. So for the choices here, which one sounds the best is the patient who needs to be on a MIRA but's having side effects from that. The one that sounds to me is going to be A. So the key, once again, is to optimize medical therapy. I mentioned earlier that aldosterone antagonists, are indicated in all patients with symptomatic heart failure and normal kidney function. And I really emphasized all patients because it's, MIRAs are often underutilized on wards and the boards. And for using spironolactone, for using eplerenone, you got to have a somewhat normal kidney function where the estimated GFR is going to be at least greater than 30 mLs per minute. Eplerenone, the answer on this question is the select aldosterone receptor antagonist with fewer endocrine side effects such as gynecomastia. And I can't say enough, the risk of angioedema is higher with valsartan sacubitril than with ACE therapy. So with that history of having angioedema with an ACE, you can't do it. So let me throw one more drug out there that's not FDA approved for heart failure per se, but we definitely use it in chronic kidney disease. This is finerenone, and it's another MIRA. And when someone comes in and has, kidney disease, chronic kidney disease, it does not replace your diabetic meds or your hypertension meds. It's a once daily tablet. And this is a medication that we consider in chronic kidney disease after ACEs and ARBs, after SGL2 inhibitors, then we can consider adding this medication. The reason why I just mentioned it is that this medication got approved if the eGFR is less than 30. So there is maybe a thought process if someone comes in with CHF and you need to be on a MIRA and their GFR is less than 30, maybe this is something to think about in the future. So what about this 43-year-old man is evaluated during a follow-up visit for heart failure with reduced ejection fraction and type 2 diabetes. He is currently without symptoms. Meds are metformin, valsartan, sacubitril combination, metoprolol succinate, eplerenone, and a statin. On exam, he is normal tensive, heart rate 64. There's no S3 on auscultation, no JVD, no peripheral edema. Hemoglobin A1C is elevated at 7.0. Which of the following is the most appropriate additional therapy? Well, A is digoxin, and there's no indications for doing digoxin here. It's not one of the 4 pillars, so it's not going to be A. B is using an SGLT2 inhibitor. Well, this is the patient who has heart failure, who is a type 2 diabetic, and A1C is not a goal. This seems like a great match right here to begin with. Giving more Lasix or including Lasix, well, patient is no peripheral edema, no JVD, no S3. I don't think there's indication at this time to initiate, a loop diuretic. And once again, the heart rate 64, patients on a beta blocker that reduces mortality. I don't think there's a need to add a sodium funny channel inhibitor with ivabradine at this time. So this is going to be a classic question where this patient needs an SGLT2 inhibitor. And SGLT2 inhibitors have overlapping circles. Of course, we could use them for type 2 diabetes. We definitely could use them for cardiovascular disease in people with HFrEF and HFpEF. And last, SGLT2 inhibitors, I mentioned this already, are used in people with chronic kidney disease. And in our diabetics, we always check that, that spot urine albumin to creatinine ratio. And depending on the value, we could think about adding SGLT2 inhibitors to things such as ACE inhibitors. So there is a lot of use when we talk about these SGLT2 inhibitors. So with that being said, I'm always staring at the time while I'm talking, and I really want to talk about devices. I think devices are going to be very, very important. Now, the 3 devices I have up here are ICD, intracardiac defibrillator. You use that interchangeably with the terminology AICD. Cardiac resynchronization therapy, which is biventricular pacing, reduces mortality, and an LVAD, the ones that we do destination therapy for. So let me talk about some devices that are out there. Many of you may have heard of something called the implantable pulmonary artery pressure sensor. We call that the cardiac MEMS. It has been around for a while. These are placed in the distal pulmonary artery, and they're used to remotely monitor pulmonary hemodynamics. So really, it's like a portable Swan-Ganz catheter. And what is this device measuring is the pulmonary capillary wedge pressure. The pulmonary capillary wedge pressure tells me what's going on the left side of the heart. And wedge pressure is going to be an indirect measurement of left ventricular and diastolic volume, which means preload. So when I get readings from the cardiac MEMS from a pulmonary capillary wedge pressure, it's going to tell me volume status. So when you get measurements that say this patient's volume overloaded, if you have a nice setup, you could prescribe the patient things like loop diuretics to prevent them from getting hospitalized. So the trial that showed this was called the Champion trial, and they definitely reduced heart failure hospitalizations. So I just wanted to mention this. This is not something that reduces mortality, but it definitely will reduce hospitalizations. But what are some 2 devices I want to mention? Now, both of these devices have been around for that 2 years plus. So are they going to be the right answer on the board exams? Probably not. But could they be distractors? Could they be test questions to see how many people heard of these devices? It's always going to be possible. So the 2 ones I want to talk about called the Barostim and the cardiac contractility modulator stimulator, otherwise known as the optimizer. The Barostim, like it sounds like, it stimulates the baroreceptors. And of course, when we talk about baroreceptors, many of us think back to someone comes in with atrial fibrillation, and you're going to, stimulate the afferents with a carotid massage. At least I think of that. And when you stimulate the afferents, what happens to your heart rate? It goes down. What happens to your blood pressure? It goes down. So of course, you're decreasing sympathetic, you're increasing parasympathetic. So some of the indications for this is the EF is going to be, lower than 35%. It reduces afterload and heart rate. This is for New York heart failure classes 2 and 3. And these individuals in studies did have an elevated, end-terminal pro-BNP. They were fluid overloaded. This CCM stimulator is for ejection fraction between 25 and 45%. We'll dive in deeper in 1 second explaining what a cardiac contractility modulator is. It somewhat improves, optimizes, I used our word, contractility, and it's FDA approved for New York Heart Class 3. So let's talk about Barostim. It's novel, which means it's new. And what does it do? Kind of what I said already, which is it's a device, and the best part of this device, it has nothing to do with the heart. Unlike other heart failure options, Barostim does not touch the heart itself. It utilizes electrodes that lie on the patient's carotid artery. And like I was mentioning about, stimulating the carotid, stimulating the afferents, it's going to decrease sympathetic activity, which is good. So it'll lower the heart rate, and it actually will lower the blood pressure. So indirectly, it's going to be lowering the heart rate, improving afterload. These are different things that can help out in someone with heart failure. The 2 studies I put up here is just showing that, the Barostim is an option for people who don't qualify for CRT, which is cardiac resynchronization therapy. And the reason why I wanted to say that, of course, what are the devices right now that clearly are going to reduce mortality? I'm just going to say it once again. Do they qualify for an ICD? Do they qualify for cardiac resynchronization therapy? Do they unfortunately need an LVAD for destination therapy? Are they on the 4 pillars? These are things that are going to be that we always look at first. But if they're not a candidate for CRT and we want to improve their functionality, then we could consider doing a Barostim. And the best part is it doesn't even touch the heart, which is good. And their studies show it improves exercise capacity, improves quality of life, and had a better outcome in reducing end-terminal pro-BNP. So once again, this is going to be something that will help out with heart failure symptoms. And usually they can be used in combo with cardiac resynchronization therapy if they eventually qualify for it. But you could think about these in individuals who don't qualify for it. And always you want to do mortality reduction first. The other device I want to mention is called the cardiac contractility modulator. It goes by the brand name, the Optimizer. And the key thing about this is that, well, I always laugh, it's a minimally invasive implantable device. Well, of course, everything's minimally invasive. It's not yourself, but it is. And it really delivers precisely timed electrical pulses to heart cells during the absolute refractory period. So when is this? What are we thinking about? We're not thinking about the pacemaker cells. We're thinking about the non-pacemaker cells that had that little long plateau, that long absolute refractory period. And what does it do is that it's not a pacemaker or a defibrillator. It's designed to control the strength of contraction of the heart muscle, not the rhythm. It controls the strength of contraction of the heart muscle, not the rhythm. So this is going to be a device that got FDA approval. It actually helps out improve 6-minute walk. It actually will improve quality of life. It can improve your functional status of heart failure from like class 3 to class 2. So this is another thing to consider in some patients.